Well, let's start. Good morning, buenos días, buenas tardes, buenas noches. Good morning here in this side of the world. Thank you for joining us in this next version or next episode of this Latin American series. It's part of the Latin American engagement strategy of the George Institute for Global Health, which is based in Australia, but has offices in India, China, and the UK. My name is Jaime Miranda. I am the director of the Chronic Center of Excellence in Chronic Diseases, which is at Universidad Peruana Cayetano Heredia in Lima, Peru. But here I am connected from Sydney, Australia, where I came on secondment to the George Institute for Global Health to support and facilitate this connection and opportunities between Latin American scientists and this side of the world. And this event, named the Coffee with Latin America, is one of these casual spaces for sharing and for learning from each other. So to this day, we have a topic around stroke. And here I hand over to my co-chair, Cheryl. Over to you, Cheryl.
Thanks, Jaime. I'd also like to extend my welcome to everyone who's joining us today. And thank you for having me. It's a great opportunity to co-moderate this Coffee with Latin America session on stroke. My name is Cheryl Carcel. I'm a senior research fellow and neurologist at the George Institute in Australia. And just to talk very briefly about stroke, it's the second leading cause of death worldwide, exceeded only by heart disease. Each year, over 13 million people have a stroke and approximately 5 million people die from this condition. And there's an abundance of research on the prevention and acute treatment of stroke. However, of the 80 million people currently living with stroke, many are left with a range of disabilities, including physical, cognitive, and psychological. So there's quite a bit of things happening after stroke too. And today we will focus on those living with the aftermath of stroke. Just really quickly before I introduce our first speaker, there's a Q&A at the end, and you can pop your questions in the chat box, and you can put it for all panelists and attendees, and we'll be reading them out after the last speaker. So our first speaker for today is Dr. Paula Munoz Venturelli. She is a neurologist, and she's also a director at Centro de Estudios Clínicos in ICIM UDD. She is a senior research fellow at the George Institute, where I met her, and she'll be talking about stroke academic research collaboration within Latin America. Over to you, Paula.
Thank you very much, Cheryl. So thank you for inviting me to this coffee time session, and I would say glass wine session for the LATAM group, and for the opportunity to highlight the importance of stroke and academic collaboration in the area. So today I would like to discuss with you an area that is generally underrepresented in the scientific literature, that is the backstage of large academic collaborative clinical trials. And I would also like to acknowledge all the people and families suffering because of COVID-19 pandemic. So next slide, please. To start, just to remember something that you know, that is stroke is one of the leading causes of death and disability worldwide. Regarding Latin America, we know that despite reductions in age standardized rates of death and incidence in many regions, the absolute numbers of stroke and its burden are increasing. Next, please. Latin America is an heterogeneous region where we have large differences in cultural, social, economic, and political aspects that pose significant challenges to efforts to unify and standardize stroke care and research. Next, please. In a broad effort to improve stroke care in the region, a recent Pan-Latin American meeting was held in Brazil, led by representatives to expose the characteristics of stroke care. The need was clear for systems to be better organized, which will probably require greater investment in order to increase the ability for patients to access the best available treatment, including rehabilitation and post-discharge care. And regarding research, a special call was done to implement research in stroke based on the priorities and realities of each country. Next slide, please. We also know that the importance of research partnerships to improve health in Latin America in order to translate evidence-based intervention into clinical practice, and also to understand how health systems influence outcomes in stroke. We have participated in several influential global stroke research projects over the last decade. This work has strengthened local research capacity, has allowed new knowledge generation, and has improved population healthcare, highlighting the importance of international linkage. Next, please. So over the last decade, many investigators in Latin America which have required the collection of minimal essential data on the testing of simple interventions within the context of routine clinical practice. For example, Universidad del Desarrollo in Chile provided the regional coordination and monitoring for INTERACT-2, the second intensive blood pressure reduction in acute cerebral hemorrhage trial, which determined the effectiveness of early intensive blood pressure reduction and included 50 patients from Latin America. A crucial challenge for this study was the inclusion criteria of a short time window, less than 6 hours, from symptom onset to randomization. And as many Latin American centers were located in areas with suboptimal population awareness, patient recruitment was compromised by delays in arrival and also busy emergency departments. Next slide, please. We are currently participating in INTERACT-3 with active recruitment that aims to evaluate intensive care bundle that includes blood pressure reduction, but also temperature, glycemia treatment, as well as a reversal of anticoagulation in the outcome of acute cerebral hemorrhage patients. Unfortunately, the cluster randomized methodology was impacted by COVID-19 pandemic, adding difficulty to patient recruitment and intervention because of services reorganization. And next slide, please. Another project that was the enhanced control of hypertension and thrombolysis stroke study, the ENCHANTED trial, designed to compare low dose with standard dose intravenous thrombolysis and intensive versus guideline recommended blood pressure management in patients with acute ischemic stroke. Again, rapid recruitment, the efficient informed consent and randomization were often challenges for many investigators who were overwhelmed by clinical workload in the emergency department of participating hospitals. Next slide, please. Finally, in the head position of acute stroke trial, the HEADPOST trial, that was the largest stroke trial involving more than 11,000 adults who were randomly allocated to a lying flat or sitting up position, including 910 participants from Latin America. This study was a cluster crossover randomized design and with a guardian consent process that were highly innovative for the region, which allowed rapid inclusion of patients, yet the monitoring of patients and fidelity to the protocol and reporting were still challenging to many investigators with limited research experience. Next, please. So I would say that in addition to the sense of achievement to contributing to the impactful results of these trials, there was increased awareness of stroke among health professionals, and they facilitated development of local systems and pathways for the assessment and treatment of patients. And these large stroke trials academic collaborations have also provided data from the main results to inform local guidelines recommendations and allowed investigators to participate in further secondary and exploratory analysis to understand relevant gaps and barriers in stroke care systems. These are examples showing that high quality and minimally funded academic research can be conducted within busy clinical workloads and low-resourced health systems in Latin America. However, considerable efforts are required to further develop and a sustainable program of stroke research in Latin America, where investigators have the ability to undertake their own and hopefully even lead global trials. Next slide, please. One major challenge to developing research capacity in the region is attracting and retaining talented individuals to be trained in research. As the public health system does not incorporate full-time or fractional research appointments, those interested in and committed to research need to find outside funding where there are often limited opportunities. We know that clinical trials require a strong organization and infrastructure that is infrequent in the region. And for those health professionals who have a passion to develop an academic or research career, the limited research funds restrict them to undertaking small single center studies rather than undertaking large projects of international significance. Another issue is that only few professionals have experience in the design, organization, and analysis of collaborative and multi-center clinical trials, which require familiarity with a number of things like managing human resources, financial systems for salaries and the reimbursement of direct costs and overheads, processes for ethics, regulatory approvals, etc. Next slide, please. So given stroke is a leading cause of death and disability in Latin America, it is a key health priority. Even that proven therapies and intervention exist to prevent and manage stroke, we know that they are still underused in this large region of the world. Considerable work has been undertaken to build an academic network for stroke research in Latin America, with increasing participation in landmark trials. However, there is a need to generate more and better local data in order to enhance our understanding of how best to reduce the burden of stroke in the region. And finally, capacity building to increase the production and quality of research should positively impact on health outcomes. The next, please. So I can't finish without acknowledging all my colleagues from the Centro de Estudios Clínicos at Universidad del Desarrollo, and also all other collaborators not appearing in this slide from the many hospitals and universities we work with, and also our participants and their families. Thank you.
Here's a note. Thank you very much, Paula, for this presentation. Everybody's welcome to introduce one burning question now, or we can save them towards the end for the conversation. But an invitation to use the chat option with the option to all participants. And I see some interaction, so glad to see hi to Eugenia and hi to Nathan, that more ideas are flowing through. Congratulations, Paula, and let me introduce to Jessica, and thinking about training and attracting the new generation of scientists. Jessica is one of those training medicine and very much interested in research and implementation science and complex interventions. So Jessica will share with us this project that also got affected during COVID. The title is there, and it's pretty much about the experience of someone having a stroke in this, well, last year, that particular year, which was obviously very difficult on so many fronts. So Jessica, over to you, please.
Hello, thank you for the opportunity to present the project. And as Jaime mentioned, the original idea wasn't this, but during the project, we decided to pivot and explore the experiences of the patients. So can you please show next slide? Okay, so like as we already know and has already been mentioned here, stroke care is complex and it usually involves different settings, different healthcare personnel, because you have to work on different fronts. And particularly after discharge, you have to work on potential disabilities, and you also need to try to control stroke risk factors. So for example, hypertension and diabetes. And these patients not only have the stroke and the potential disabilities, but also these other risk factors. So care is usually complex. And in Peru, we already know that less than 50% of the stroke patients actually return to a consult a month after the stroke, and only 30% access and complete rehabilitation treatment. So there are different reasons why we think this might happen. Some of them are, as I mentioned, the difficulty to navigate the system, the lack of familiarity of the patients and caregivers to actually traverse or navigate it, but it's also not knowing what care they should follow. So it's part of the lack of education or information provided to them, and also the fragmented healthcare system. So as I mentioned initially, can you show next slide, please? Okay, so the initial idea we had was to develop this cascade of care for stroke patients and try to identify how many patients were treated at a healthcare establishment, how many of them had a risk factor, for example, hypertension, and were aware of this condition, how many of them received treatment, and how many of them got control. And the idea to have these steps mapped was to actually prioritize which ones were the most important. So like trying to select one and then try to better understand that step and try to find potential solutions. But what happened was that when COVID or the pandemic hit Peru, in general, the management of chronic conditions changed, with resources being allocated to COVID instead of the management of these chronic diseases. So the whole process changed. And we decided at that moment to pivot, and instead of trying to do this more quantitative study, we decided to explore the experiences and the process of care and the continuum of the care during the pandemic. So next slide, please. Yeah, okay, next one. Yeah, so what we knew at that moment was that COVID had affected healthcare systems in general, particularly chronic conditions. As I mentioned, it was a matter of reallocating resources. So there were disruptions in the continuity of care. And in the case of stroke, at the beginning of the pandemic, most of the studies were focused on management, acute management of stroke, and they were not assessing the continuity of care and what happened with these patients after discharge. And another issue was that Peru, as you might know, has been really affected by this pandemic. We had a lot of mortality due to COVID, and also the healthcare system was really impacted. So that's why we decided to explore what happened with care for these patients after the discharge. Can you show the next slide, please? Yeah. Okay, so we had two specific aims. The first one was to understand what happened in this transition. So when patients are hospitalized to receive acute care and then they are discharged, and what happens in this process. And the idea to identify this was to then try to suggest potential opportunities or potential interventions to try to improve this process. The next one, please. So in the end, we conducted a qualitative study at the Institute of Neurological Sciences. This is a national referral center for stroke. It's based at Lima. And we included both patients and caregivers who had stroke and that were discharged at least 3 months previous to the interview. So we wanted to know what was their experience like after being discharged, when they had tried to contact the healthcare establishments. And we also invited healthcare providers that were, or that participated in stroke care. And not only neurologists or physicians, but also nurses or technical personnel that helped during rehabilitation therapy, etc. And the idea was to get a comprehensive understanding of the process and what actually happened. Next slide, please. Yeah. So we had 2 moments. So far, we have conducted the first one. We conducted individual interviews with the participants I already mentioned, and the output was a journey map. A journey map is well, as the name says, it's a map where you can see the phases, the different phases of stroke care, the objective of the phases, but also the experiences and the emotions that arise at each of the phases, and the potential solutions that patients or the person going through the journey can provide. That was the first part. And in the second part, what we want to do is try to share these results, this journey map, and generate discussions with healthcare providers to try to understand what would be potential solutions to improve the care they're providing. Can we show the next slide, please? Okay, so far we have conducted 11 interviews to patients and caregivers, and also we have worked with 7 healthcare personnel. Well, the numbers were decided based on saturation. And what we have found in general is that there were difficulties in different phases of the continuum of care. Can you show the next slide, please? Okay, so what we see here, this is a summary of the journey map, and we can see there are 5 phases. The first one is the pre-hospitalization. We didn't explore that in detail, but in this phase, the idea is that patients and caregivers identify the signs and symptoms of a stroke and decide to go to a healthcare establishment. Then we have the acute management of stroke that is conducted at the emergency rooms. And then we have the hospitalization phase. During this phase, the idea is to try to study and identify the causes of a stroke and then try to control risk factors. And then we have this phase, the discharge process, that actually happens during hospitalization, and it should aim to prepare the patients and the caregivers for what is going to happen after the discharge. And then we have what happens after discharge. So the idea after the discharge is that patients continue their treatment, continue the management of risk factors, and try to reduce or treat the potential disabilities. And what we can also see here is, well, I'm sorry it's in Spanish, but we have some feelings, and the idea is to see how the feelings change according to the phase and how different feelings arise based on the experience patients have. And then we can also see what expectations patients have for each of the phases. So what do they expect from the healthcare system and the providers? And just one simple example, you can see in the hospitalization phase and in the discharge process phase that what they are hoping to get is clear information, response to the question. Why is this? Basically because during COVID, visits from the family members were not allowed in the hospital. So the communication was really difficult, and there were only like phone calls that didn't actually work. So that's why one expectation they have is just to communicate. Can we show the next slide, please? Okay, so those are like in general the results. And the difficulties we faced were related to the registries. So to contact the patients, we had to use the clinical records and try to find the patient's name and phone numbers. But this information was not updated, so we couldn't contact everyone, and some of the patients would not answer. And then in the case of healthcare providers during COVID, and I think in general, there is a lot of workload, and it was difficult to conduct virtual interviews. So we were asked to go to the healthcare establishment to do face-to-face interviews, which was a little difficult during the pandemic. And also it was not possible to actually conduct focus groups because gathering people in the same room was a little bit difficult during COVID. Can we see the next slide, please? Yeah. Okay, so the conclusions is, well, the first one is that we found a disruption in the continuity of care. And as I presented, there are some expectations of the patients that might not be seen or heard usually. So another conclusion is that these perspectives, feelings, emotions, expectations should be considered when prioritizing and developing solutions. So potential steps we have for this project is maybe to develop or co-create an intervention to improve communication, as it seems to be one of the pain points that patients have highlighted. And the other is to present or share, disseminate the results with the Ministry of Health and try to explore the referral system and identify opportunities to improve it. And next one, this is, I think this is the last one. Thank you for your attention.
Thank you, Dr. Zafra. Our next speaker is Professor Richard Linley. He is the Deputy Dean of Sydney Medical School at University of Sydney and a professorial fellow at the George Institute for Global Health. He's also a geriatrician and a stroke physician. And Richard will speak to us today about post-stroke rehab in LMICs.
Thanks, Cheryl, and thanks for this opportunity to speak with you, and hello from lockdown Sydney. Some of you may have seen in the news that we have a Delta variant outbreak in our unvaccinated population. So I'm working from home today on my university day. The background is my public hospital that I work in. Next slide, please. So moving straight on to the topic, if we think about how rehabilitation can realistically occur in low and middle income countries, I think we need to think of three main models. The family delivering the rehabilitation, which is a model that developed down in Trivandrum in Kerala, south India. We could consider a single health professional visiting someone in their own home, or we could consider the patient surviving with stroke in the community going to a community centre and receiving care there. So what I want to do is show you some evidence that we've tried to gather on a couple of these issues. Next slide. So we, in an international collaboration, and it's really reflecting what Paula and Amy were talking about, with a fantastic international collaboration, including people from Britain, Australia, and of course India. We managed to pull off this amazing trial called the ATTEND trial, which was funded by the Australian government. And this was really testing the Indian model that Jayaraj Pandyan was very enthusiastic about. He'd seen it established in Trivandrum down in Kerala. Now, with the team of international team, we put together an intervention that was based on the best evidence, particularly motor relearning activities. We put the evidence from the carer intervention trials that have been done in the UK, and it was made culturally appropriate and tested in a pilot study. The study, after a few attempts at getting funding, I think we put in 3 major grant applications. We did get funded by the Australian government. And with the fantastic team in India, we managed to recruit 1,250 patients. And the bottom line was that having done this intervention, and I must say that this, of all the trials I've helped run, I thought this was going to be very positive. And it just goes to show how wrong you can be, because it was neutral. Our intervention had exactly the same results as our control group in every aspect of health that we looked at. Next slide. So we've obviously done a lot of soul searching and discussion since then. And these are our thoughts of why the family-led rehabilitation idea didn't work. First of all, in ATTEND, we only managed to achieve half an hour, 30 minutes of rehabilitation activities in our intervention group. And Western medicine inpatient rehab generally delivers about 2 hours. During the course of the trial, we found that some of the components of carer training that have been looked at in the TRACS UK trial but may not have actually been effective. We must say, though, that the process evaluation found that we delivered the intervention exactly as planned, and the intervention was very popular with our patients and their relatives. But our intervention was unidisciplinary. We only had one trainer for the family, and effective rehabilitation usually requires a team of therapists. And then, of course, we have the cultural attitudes. And I put on the slide a lovely cultural issue I discovered in China, that in Beijing, if you're female and you're unwell, you are entitled to 100 days in bed. And of course, we need to address the local cultural issues of illness. In India, it's quite acceptable to look after someone in bed for years, and commonly done. And overall, and Marie, who's on this webinar, was key in all of this, we realized that our intervention couldn't be a task shifting alternative to a known complex intervention. But, you know, what was really interesting, and in our final results meeting with our trial staff, we realized that in our training sessions that we had with the physiotherapist who was training the family members, we found that there was so much crisis going on, so much counseling going on, that maybe we just didn't do enough training. Next slide. And this is really interesting, because looking at Jessica's slides that she's just presented, Lutz published in 2011 a very similar profile. When you have a stroke and you come into hospital, you can see in the middle arrow, phase 1, you're in crisis. You then perhaps relax a bit in the hospital, and then phase 3, you're in crisis again. And how can we expect patients and their relatives to learn when they're in crisis? Maybe our intervention was also too soon to have a benefit. New slide, next slide. Around the same time, my Chinese collaborators at the George Institute China, led by Li Jing Yan, were very keen to do a sister trial to ATTEND. But we thought we should probably try something a little bit different. And in China, what we decided to do was a nurse-led rehabilitation within the hospital and with support thereafter, based on improving basic activities of daily living based around the Barthel Index. So this trial was run fantastically well by my Chinese colleagues. And this was not only, not positive, it was actually slightly harmful. A real shock. So a single uni-health discipline intervention with a nurse wasn't the answer in China. Next slide. So let's think about this again. So do we need the expertise of qualified therapists? My therapy colleagues tell me, of course. We've already talked about the fact that it may be difficult to task shift this activity. The World Health Organization loves task shifting because it saves money and it's good for simple things like vaccination. But maybe we've discovered a problem that the rehabilitation may be a careful balance between the time window of brain plasticity and recovery and getting the person over the crisis of their stroke. And then I suppose we then ask the question now, what are we trying to achieve? Next slide. While we presented this at the international conference in those olden days when we could meet and travel, we came across this amazing lady called Rita, who was a retired stroke nurse from London, who'd gone back to Nigeria and set up a community-based rehabilitation for stroke. And she published her little audit of her centre and showed an improvement in the Balfour Index with her centre-based care. Next slide. And so Rita, having done this work, and she's set up, there's a website you can look at, Stroke Action Nigeria, that is still active. I checked it last night. Maybe this is the way forward. Next slide. So what do I think of all of this, having failed to find something that works? Well, what we were going to do, and I met this amazing Bangladeshi researcher who'd done work of finding all the children with cerebral palsy in a geographical area of Dakar. We had planned to do a prevalence study in his geographical area in Dakar and count the people with stroke living in the community, and then ask them what did they want in order to improve their outcome. And of course, what we're talking about here is consumer co-design. What do people in your community want, and how many people are there? And so my final conclusion is that we didn't manage to do the Bangladeshi study because COVID arrived and that project has had to be postponed. But I would just like to raise the issue that would a centre-based rehabilitation along the lines that Rita Melafonyu had trialed in Nigeria, could this be a solution that is now worth testing? But why don't we ask our patients, our consumers, to help us design the next intervention? Thank you very much.
Thank you, Richard, very much. And sorry.
Sorry, my next few slides are just showing our team. And this is the fantastic young physiotherapy and stroke research team up in Shimla, one of our trial meeting sites. So fantastic team, and thanks to all of them.
Thank you, Richard. Let's move towards our next speaker, but it's notorious to see how we're transitioning from the capacity to conduct research in our settings, but now also listening to the words and voices of the people through Jessica's presentation and your presentation as well. Very nice reflection on how they tied up together. So let's move towards another aspect in this crisis after the discharge. So over to Marie, who is professor at the Faculty of Medicine at the University of New South Wales in Sydney, but leads the program on mental health at the George Institute for Global Health, and equally has shared appointments in epidemiology at the University of Lancashire in the United Kingdom. Over to you, Marie.
Thanks, Jaime, and thanks very much for the invitation to present today. I'm giving quite a broad presentation, but hopefully we'll get a bit of discussion in the chat. Next slide, please. I'd like to acknowledge the traditional custodians on the land. For me, in Kiama in Australia, in Sydney, that's the Dharawal people of the Eora Nation. I'd just like to pay my respects to their elders, past, present, and emerging. Next slide, please. So I'm going to start with one assumption, that we have some joint understanding of what we mean by depression after stroke. So when I'm talking about depression here, I'm not talking about, oh, I didn't get my coffee this morning, I'm really depressed. I'm talking about clinical depression, depression that you experience most of the time, most days, for at least 2 weeks, and that impacts on your ability to be you, your ability to carry out your day-to-day tasks. And I'll acknowledge here that there's likely some cultural differences in the way people present with depression, but not necessarily in the way we experience depression. But that does mean there's some cultural differences in the way people categorize and get concerned about the impact of things like depression. So these are data here from a systematic review of high quality epidemiological stroke incidence and outcome studies. And what you're looking at here is time since stroke in the black text, 0 to 1 month after stroke, up until 1 year. And population means that the participants were recruited in ideal population-based stroke incidence studies, hospital, recruited in hospital, rehab, recruited in rehab centres. And if you follow that dotted line all the way down to 31% at the bottom, you'll note that over the first year after stroke, at any time point, 1 in 3 people experience depression of clinical concern. Next slide, please. Even between 2 and 5 years after stroke, we've got 1 in 4 people experiencing depression of clinical concern. So this is a big problem impacting, the stroke survivors for a long time. Now, you've all got access to the chat, hopefully. So there were 61 studies, 25,000 participants. I'd like you to pop into the chat a guess at how many of those studies were conducted in a Latin American country. The answer is not 0. And you can also have a guess at how many participants contributed. So go away, be brave. I'm just curious to see what you think. Next slide, please. So if it's such a big problem, can we predict who will develop depression? And this would be handy because then we could have some really targeted treatment strategies. We could target those at high risk and maybe reduce that number down. So when we look at those same studies who looked at developing predictive models, there's definitely seems to be some association with stroke severity and probably associated disability. There's probably an association with history of depression, but for some reason I'm yet to understand. Researchers keep excluding people with depression before their stroke from their studies, and it's probably the single most important risk factor. And there might be some problems associated with being cognitively impaired, but of course these people are also often excluded. Next slide, please. What we did find, there's no association with some commonly reported risk factors in the general population, like older age, being female, and where you have your stroke doesn't seem to matter. So we're not very good at predicting who will develop depression. Good to see some answers coming in. You're not far off, actually. Next slide, please. So if we can't predict who's going to develop depression after stroke, should we do blanket screening? Should everyone who comes to your stroke unit or your hospital ward or your outpatient clinic complete a screening questionnaire? The short answer at the moment is no, with the exception of having a clinician who understands how to score that questionnaire, who understands what they'll do if someone scores in the high range. Will they then conduct a psychiatric structured or semi-structured interview? And they understand a pathway of care. Do they understand, would they provide stepped care? So psychological therapies, followed by drug therapies, followed by inpatient care if someone's very, very unwell. So that's the only way blanket screening works. And if we're not very good at identifying people with depression when they have it, because there's a lot going on when someone's had a stroke, then we're not very good at treating it either. Next slide, please. So these are the current management options that we have available to us. The first one, doing nothing, is actually evidence-based because in an ideal world, if someone comes to you with mild to moderate symptoms, you'd assess them again in 2 weeks' time to see if the symptoms persisted. People self-manage with a variety of different treatments. We have done a systematic review that it looks at talking therapies, antidepressants, and non-invasive brain stimulation in existing clinical trials to see if they are effective treatments. Next slide, please. So this particular treatment review was updated last in 2020, and we're updating it now. You'll also notice in the white box that we looked at combination interventions compared to single interventions as well. Next slide, please. So I'm going to start where I usually finish, which is that the variation in the quality of the trials was large and predominantly quite poor. There's a really large range in time for recruitment into these studies from stroke, anywhere from 2 days to about 13 years. So it's hard to say these participants are comparable. The general trial procedures, especially in the older trials, weren't the best. So not concealment of randomization, not blinded outcome assessors, small samples, short treatments. There was selective reporting of multiple outcomes. And the big concern here is to do with depression, which was often measured multiple ways within a trial with no primary method identified as the primary outcome. And especially when it comes to drug therapies, antidepressants, adverse events were seldom systematically recorded or reported. Next slide, please. So rather than go into detail, because you can all access that review and the prevention review as well through the Cochrane Library, just a brief summary is that we have evidence to show that antidepressants do treat depression to remission. They also reduce depressive symptoms, but they are associated with an increased risk of adverse events. So you have to really balance the benefits of risks. And in a lot of the low and middle income countries, we have to think about access to many of these therapies, that they might be off patent, but they simply aren't available. Talking therapies also decreased depressive symptoms, but because of that multiple methods to measure the outcome, we didn't pull the results. So there's some evidence for the combination therapies, but again, they didn't look at the binary endpoint of depression as an outcome. So we've got quite limited evidence. Now I've got a second question for you as I finish up. Out of these clinical trials, how many trials were conducted in a Latin American country and how many participants contributed? Now I'll just quickly go back through those methods. We've got 5, 3, 2, 2, and 3. Well, the person who's got 3 there, we have one observational study conducted in Martinique and 2 conducted in Spain. And in total, they contributed 410 participants. But that's really not a lot. Latin America is quite a large population. So the evidence that's been used to base clinical care in Latin America, I'll tell you that the answer for the trials is 0, is very, very limited. So here's your opportunity to develop some really good interventional research, probably using a variety of different interventions. And my next slide is my last slide. Thank you very much. That is me, by the way.
Thank you, Marie, and thank you to all the panelists. And let's try to make the most of having you all together on this, reflecting together. And to me, one thing that caught my attention is not only having the preparedness with all the tools and the procedures that are essential, but sometimes also how do we develop interventions. So my question, perhaps Richard has touched a little bit on this. How would you do it differently, right? And Marie has also told us that there's very limited evidence coming from Latin America. So question for all the speakers from my side is, given that opportunity in the sense that there are capabilities existing, but they haven't tapped onto this topic yet, what will be the next study to be conducted in Latin America?
A funded one.
Yeah. Let's assume if there were to be a funded study.
You know, and this is a very serious question, Amy. The way you can get funding in Latin America is by partnering with people in richer countries like the UK, the USA, Australia. There is a model that this can occur. And of course, we've now got some global funding through you know, some of the big new foundations like Melinda Gates Foundation, but they don't tend to fund trials at the moment. But it's all about partnerships. It's all about getting to know people in other countries and working together. Now, one thing I didn't mention about the ATTEND trial is that it caught the attention of the head of the Indian Council of Medical Research, and it came at a great time, a high-profile trial published in The Lancet, and we managed to get recurrent Indian funding for a national Indian stroke research network. So by external funding from Australia precipitated new national funding in India. And in fact, that's our major achievement. We
Fantastic.
had capacity building, and we have a, we had 35 full-time staff in that trial, and all of them were, I hope, trained and had research capacity experience, and they've gone on to better things. So this is why these sorts of webinars are so important, to just connect people together, and let's look at what opportunities arise globally.
Indeed. Paula or Jessica? Or if not, let's move to the next question, Cheryl.
I completely agree with Richard. So probably one of the good things that we got from one of the trials is this collaboration with Australia, and also with to apply for a grant for the UK. So it was very important to have this collaboration to show actually that it would be including sites from countries, low income or middle income countries. And it was, I think, a very good strategy for us as well, because funds in our region are very restricted, and it's quite difficult to perform large clinical trials with national funding from Latin America. So the collaborations are very important for this.
Thank you.
Thanks, Paula. I think my next question is also for Paula. Aside from funding, what do you think is key to keeping the momentum going for your collaboration? And you mentioned already that this is such a heterogeneous group. So what's key there? How do you keep things together? How do you keep things rolling?
Well, I think of course funding is a very important part of the result, but I think also a good project, like if we can motivate our colleagues to do clinical trials that would really answer relevant clinical questions and could actually improve their activities and healthcare and processes. I think that this can really get people connected and within the network, because academic trials, of course, don't have, as the industry trials, all the funding that helps a lot to motivate the groups, and having a good idea and having good solutions as well, or try to get solutions to important problems in the region. It's very motivating and really keeps people unified and within the group. I think so. Having a good clinical question and having an interesting project for everyone, probably related also with consumers, that is quite important, and was mentioned as well, trying to involve consumers from the different countries, and to try to get the projects very with a shape of what we need in our regions as well.
There's one question from Koyo, and before the question to Marie, COVID has disrupted health systems, and we have seen that closely through many of our contacts. So And linking to the presentation of Jessica, where it caught my attention, these feelings of the post-stroke discharge, it was abandonment, and that connects with Richard's slide of this crisis after stroke, and then Marie's experience. So I would like to invite a reflection from all the speakers on how to think about this post-stroke care now with during COVID times, and perhaps the timing. So when to provide this companion, because as Richard mentioned, there were these multiple crises going on afterwards. So too much information and the capacity to absorb new recommendations. So any reflections on that?
It's Richard here. You know, we're in a very difficult situation, and you know, Australia has found itself in a very difficult situation this last week because of our slow vaccination rollout. So, you know, I think the World Health Organization is quite right to point out if the rich countries don't help vaccinate the poor countries, we're all in this together for a long, long time. So I can only see worldwide collaboration in vaccination as our way out of the COVID crisis. Going back to the stroke care though, last year during the early stage of the pandemic, we had to move to a geographical based system. So my geography was the stroke rehabilitation ward in a small subacute hospital. That's all I did for 6 months. And I had this view that we just did the same stroke rehab medicine as we should do. And in our multidisciplinary meetings, we just had one therapy member, all spaced out in a very large gym, but we did our usual stroke care. And I think that is my basic message. Within your own resources, try and maintain your own standard of stroke care and be an advocate for the patient with stroke. And that's how we try to run our own service.
Thank you, Richard. Thank you. Marie or Jessica or Paula?
Yes, so related to, in general, chronic conditions care during COVID, I don't think there's no single answer, but in Peru, there were some measures that were like proposed by the Ministry of Health and to some extent actually implemented. And in general, what they were trying to do was try to decentralize care, because in Peru, particularly, most of the care for chronic conditions is provided at hospitals. So they were trying to reinforce and strengthen the primary healthcare levels and try to like reduce the workload from the hospitals that were actually caring for COVID patients. And they tried to implement telemedicine. Also in the case of rehabilitation, they were implemented telerehabilitation. And I think that helped a little. They also try to get closer to the patients' houses. So like contacting them, trying to go and see if they had the medicines or not, if they didn't, try to deliver them. And as I mentioned, this wasn't implemented at 100%, but I think there are some solutions that were tested and maybe we just need to try to strengthen them. Like, and yeah, work with the resources we have.
Marie, sorry, would you like to add or?
Being a non-clinician, I'm not going to hazard any suggestions about how we care for people in the setting of COVID.
Yeah. I think we're getting to the time, so no, care for people always. I think what we're seeing also gets translated to the family and the household, isn't it? In the absence of structures, and that's also an important burden, something to tackle onto. Any final reflections? So over to the speakers. Would you like to share anything with us before we close? Or Cheryl?
I'll add something. And for the mood and communication areas, I think some of the really novel work, Jaime, is some of the work that your team have shared, you know, with having to think of more novel solutions, ones that aren't drug-based or chemical-based. The stroke survivors we work with really want to try talking therapies and other solutions before they take medicines. So anything that involves things like text messages, writing to people, socializing, talking to people, you know, who knew that might work? Yeah, all of those options would be lovely to see, and they're often cheaper than running a big drug trial.
It reminds me of with Jessica when looking through her preliminary results, it's like post-stroke discharge means like a divorce from the health system. It's goodbye. And that's putting a lot of pressure on the families, and that's a big responsibility for us to address that better. And I suppose that's the motivation of this session, to see across the multiple stages of not only having a stroke or having the capacity to deal with the acute event, the challenges ahead of us, of what it means living with a stroke, not only for the patient, but also for the caregiver and the families and the household, particularly in LMIC settings. So thank you everybody for this reflection. I think it combines really well all these lessons or all these challenges across the patient journey map, that it doesn't end after the discharge. So thank you for making that visible and bringing our attention to that aspect as well. Sometimes we think that health systems are healthcare delivery systems, and we see that there's a massive need to be also stronger and responsible of reaching out those in need outside of the healthcare facilities. Cherry, over to you for the final words of closing and saying goodbye.
Thanks, Jaime. Thank you, everyone, to all our speakers for joining us today, and also to our attendees. We've had some really stimulating conversation, and if you want to get in touch with any of the speakers or to Jaime or myself, just email us. You will have the invitation from the George Institute. You can send your email through them and they'll put you in touch with the right person. Thanks, everyone, and have a good day and a good evening.
Thanks, everybody. Bye-bye.
Thank you, everybody. Bye-bye.
Thank you. Bye. Ciao.
Bye. Thank
Ciao,
you.
ciao. Adios.
Buenas noches. Adiós.
Buenas noches, Paula. Ciao.